And thank you everybody for attending today. It looks like we have a really good turnout for this webinar. And we'd like to also thank our presenters uh, for joining us today. Justin Kinoti and Paul Hart. I'll hand it over to you, Anthony, and enjoy.
Thank you so much, Holly. I think you will give Kinoti space to share the screen from his side. He has made some changes to the slides, Dr. Paul. So you will interact with him and get to know the changes that he has made. My name is Anthony Kimathi. I'm the country director for the Addis Clinic. The Addis Clinic is an non-governmental organization that works in East Africa mostly, but we are not limited by geography. We can go any part of the world and are comfortable to say our work can be felt in every corner of the world. By having people like Dr. Paul on board, I can comfortably say that our presence is felt in US, our presence is felt in West Africa, East Africa. We have 5 thematic programs. The first program being the telemedicine program that we currently enjoy as clinicians and healthcare workers, frontline healthcare workers, every part of the world. If you are not part of it, please reach out to me. My number, I will share it in the chat. My email, I will share it in the chat. We use our telemedicine platform to consult on cases. In case you have a complex case where you are working, we always welcome you to send it to us, and we'll be able to help you diagnose and treat it. The next program that we have had for the last 6 years is the Hem Health program that is run by Felix, part of us here. It's a HIV adherence program, and it is currently led by Felix, and we currently operating in 4 counties in Kenya, which have a high rate of infections, and they're in the western part of Kenya. The third one is the MCH program that we operate in Somalia. The fourth one is the SRHR and GBV that we operate in Kwale County. And the fifth one and the last one is the global health education. If you're not part of it too, please reach out to me. I will be happy to include you in part of it. And this is where we include different universities and link with them and discuss cases. So we have a clinician from Kenya discuss a case with a student in Vanderbilt University and their lecturer, and they can have a video call and discuss a case together, and even have a patient with them and clerk the patient and try to go through the patient. Our main aim as the organization is to empower the frontline healthcare workers. That's actually our biggest plan. And as you see these webinars, we don't discriminate who can join. The public can join, anyone can join, as long as you learn something small. We are happy to have you as part of us and always be available to, because every month we have a webinar, and we ask the attendees to choose a topic that they think we can tackle together. And this is what we are doing currently. Gastrointestinal cancers was one of the highly requested cancer topics to discuss. And we have prepared a slide. We looked for knowledgeable people in the field. And I'm happy to tell you that the presentations today, you are free to ask any question, anything that comes, any suggestion that you put. We are all learning from each other. Some of you may have different knowledge on how to handle different cases, but as we come here as frontline healthcare workers, I request of you, please be free and ask any question that you think we can be capable of responding to. Part of the attendees can be part of the group that can give a response to an answer, and we are also ready to go back and research on an answer and include you. The On all these programs, we do research and we have written different papers on different topics. And I would like you to go to our websites, to go to our social media pages, look at what we present there. And as you would like to be part of us, please reach out to me and I will be happy to include you. As high hand on that, I would like to give Kinoti the floor to present to you. You have the chat part and the Q&A. Please use the Q&A part to ask questions. Feel free to ask any question. And I give the floor to Kinoti. Thank you so much.
Thank you, Kimadi, for that wonderful introduction. Just confirm that the slides are, whether you can see slides from your end.
We can.
Thank you. Yes, so today, as it has been introduced, we are discussing about gastrointestinal cancers in Kenya, which is really a growing challenge. We know globally, but major in the sub-Saharan Africa, and more so in Kenya. And even in Kenya, in terms of how the pandemic has been distributed, or the disease pattern is distributed, still there are some regions within Kenya whereby we are seeing that the gastrointestinal cancers are more. So this is quite an interesting topic, and what we have done is that we have tried to simplify the presentation, because not only the healthcare providers who are joining this webinar, but the general public as well. So you are all welcome. So the first thing we ask ourselves is, can we be able to define cancer even before we go to the gastrointestinal part of it? So as we know, cancer very well, we can simplify it like it's a growth, abnormal growth of cells. Yeah. And these cells can be anywhere in the body. Each and every cell in the body has a potential to be either cancerous or malignant. Yeah. But you will find that there are some types of cells that has got higher risk than the rest. And one of them is within the gastrointestinal tract, and we'll be showing a pictorial presentation on which are some of these areas whereby we are most likely to have cancers as compared to the rest of the gastrointestinal tract. So, like I was saying, the burden of cancers in Kenya, it's something that we cannot overemphasize, and we need to understand the scope, the skill, and the significance of these gastrointestinal cancers across the country. And given that one, we can prevent them, we can screen for early diagnosis, and we can also start the treatment early enough before the disease progresses. So, as
I think we lost you, Justin. Kinoti, you're not audible. Am I the only one that has lost Kinoti? Can you hear him, Dr. Paul?
Okay, yeah, can you hear me?
Yeah, I can hear you, but I cannot hear Kinoti. I think we just lost
Yeah,
him.
does he, maybe he has to rejoin. He had trouble with his internet.
He's here. Kinoti, can you hear us? Hello, Kinoti, can you hear us?
He's not muted, but we can't hear him.
No, not at all.
Yeah.
Okay, well, do you want me to sort of carry on for a bit until he can come back on?
Eh, Yeah, I can I can share the slides on my hand then.
Okay, thank you. That'd be great if you could, please. I didn't pull it up on my end.
Yeah, I'm trying to pull them as fast as I can. Sorry,
No problem.
everyone.
Oh, here
These
he
are the
is. Is he back?
Cannot hear you back. Can you hear us?
Yes, I am back.
Thank you.
What happened?
I don't know, it just dropped off.
Okay, sorry for that. You can continue. You are
Yes,
in the
but
I think you're in the third slide, the
yes,
previous one.
we were where
Yeah,
yes,
that one.
where we were explaining about the cancers as a national crisis. Uh, so we understand that the gastrointestinal cancers generally, or the GI cancers, represent a disproportionately large share of Kenya's total cancer burden in Kenya. Like the esophageal cancer we'll be discussing later on, the colorectal cancers are among the leading cancers in Kenya. Of course, not forgetting we have the breast cancer, cervical cancer, and the prostate cancer as the leading. But then now after that, the gastrointestinal cancers um, take the rest um, of the positions in the top 10 cancers in Kenya. So our focus tonight will majorly be the four cancers. We have the esophageal cancer, which is the leading GI cancer in Kenya. Unfortunately, also this cancer is one of the cancers that is diagnosed a little bit late. As per my clinical experience, is that rarely do we get patients in Kenya with stage 1 esophageal cancer, because most of the symptoms are ignored. Then we have gastric cancer, and this one is another one that is closely linked to the Helicobacter pylori, the H. pylori infection, that is common in our setup, especially in areas where we are using borehole water and all that. And of course, the dietary habits. Then we have the colorectal cancer is another key one, which is an emerging and it's growing concern in our Kenyan setup, with an increasing incidence every other year. And finally, the pancreatic cancer. This one is another that is silent and deadly, and it is typically diagnosed at an advanced stage. Yeah, rarely will you find a pancreatic cancer, a patient presenting at early stages. Most of them will come at stage 3 or stage 4. But from the clinical experience, one of the things that we have seen, or the pattern that is quite common, is when the early symptoms of pancreatic cancers start to manifest, they mimic those of diabetic, or rather endocrine diseases, but majorly diabetes mellitus. So you find the symptoms are controlled, that is majorly the diabetes, and the physicians, if they don't do further screening or investigations, then the moment you have controlled the sugars, you are like, I've got it right. So they leave the patient to just control, or they diagnose diabetes, only for later on to present with a mass that is then confirmed as pancreatic cancer. So these are the four common ones that we shall be dealing with tonight. And this is just a pictorial presentation on some of the common cancers, like you can see in the esophagus. And something I would like you to take note of is, where are these tumors developing? Like you can see the esophageal, it's just at the lower side, or the lower third of the esophagus. We shall be explaining on why this is happening. What are some of the cellular adaptations that lead to this? Then you can see in the small intestines, in the colon also. Yeah, and finally we have also the anus. And something interesting is that you will find those transformations like if it's where we have the squamous cell, yeah, those that is where the cancers are likely to develop, because during their process to try to adopt the the change or adopt to a different cell type through metaplasia. So we shall be explaining that later on. So let's look at the esophageal cancer, which is, like I've said, a leading threat in our setup. And this is the most prevalent gastrointestinal cancer in Kenya, especially men. And it's the major cause of mortality nationwide. Like I said, most of the patients present quite late, and rarely do we have most of them getting to the 5-year survival because they present with either stage 3 or stage 4. Like I said, you notice with this gastrointestinal tract, they even have a pattern in terms of geographical distribution. Yeah. So for gastrointestinal tract and specifically esophageal, you will see a pattern on that, a hotspot in northern Kenya and the northern frontiers. That is all the way the northern counties of Mandera, Wajir, Garissa. Also now we also have Marsabit and Meru counties. Yeah, I know there are theories around that there was some deposits, waste deposits that were deposited there and all that, but still there are studies that are ongoing to try to get to identify what are the key factors that are leading to this pattern. So, esophageal cancer is the 9th most common cancer globally, and it is the 6th cause of cancer deaths, with over 80% of cases occurring in developing countries like Kenya. So, in Kenya, it is the leading cancer in men, and it is the third most common in women. That is obvious after breasts and cervical. And the pooled incidence is 28.7 per 100,000 people, or 100,000 persons. So you can see the magnitude of the esophageal cancer. So, like I was explaining, is that the high incidence in northern Kenya, an example is Garissa, suggests that there are strong association with the environmental and dietary factors that could be contributing to this. So what are some of the risk factors? So the key risk factors include: 1, tobacco use and cigarette smoking. So even as we go through these risk factors, just be asking yourself, what's the prevalence of cigarette smoking in these areas we have mentioned? Yeah. There has been also some studies, though some of them very basic studies, showing that there is association between development of esophageal cancer and use of hot beverages, like hot tea, use of miraa or chewing cat. Again, you see, it's quite common in those northern counties, including we have Meru and the northern counties. Then gastroesophageal reflux disease, gastritis, and peptic ulcer disease. So, what are the clinical manifestations of this disease? So, usually they are progressive and they worsen as the disease progresses. So, at early stage, that is at a stage whereby it's just a malignant in situ or stage 1 cancer, you will find that it's asymptomatic. So the patient might not develop or present with any symptoms whatsoever. Yeah, then now as the tumor increases in size, you start experiencing now other symptoms like dysphagia. This is whereby they are unable to swallow. Like it will first of all start with inability to swallow the solid foods, then it goes to liquid, then it becomes impossible to swallow, whereby there is total dysphagia. Then weight loss, and this is a key indicator in almost most of the cancers. Then the patient might present with other symptoms like chest pain, hoarseness, and chronic cough. One of the things that you find in esophageal cancer, in fact, other than the dysphagia, you might not have any other clinical manifestation that can really point towards it, unless you have a very high level index suspicion for the same. So how is it diagnosed? The gold standard for diagnosis is endoscopically, and a biopsy is taken during that for histology analysis. Also, a barium swallow can be done, as a CT scan, and PET scan. But majorly in our setup, you find that PET scan is majorly used for staging of the disease rather than for diagnosis purposes. And we know one of the good things with PET scan, unlike it will compare with other scans, but it's able to show the metabolic activity of the tumor, because tumors, I understand, they have higher metabolic activity and all that. So they are able to pick that. They're able to estimate the size of the tumor better, and one can either upgrade or downgrade the disease in terms of staging. So there are times that probably the other scans, according to the scans, because when we are staging the disease, we rely on three factors: the history and the physical examination, the histology report, that is the report from the biopsy, and number three, the imaging. So probably the results from the CT scan could have showed a different size of the tumor, but PET scan is a little bit more accurate, and through that, then a correct staging of the disease can be done. The reason why we need to get the correct staging of the disease is because staging determines the treatment. Yeah, and so when you come to the treatment and outcomes of esophageal cancer, on the approaches of treatment, number one, it's surgery, whereby esophagectomy for resectable tumors is done. Yeah, but now depending on the size of and location of the tumor, at times we can have chemotherapy either as neoadjuvant or adjuvant. When we say adjuvant, we mean that neoadjuvant, we mean chemotherapy is given, and at times even radiation is given before the primary treatment, which is surgery. So you are doing this to reduce or shrink the tumor so that it becomes resectable. Then adjuvant is after the surgery, then you give chemotherapy. Then we have radiation therapy, often which is combined with chemotherapy. We call it chemoradiation therapy. And radiation therapy is whereby chemotherapy drug is given majorly to sensitize the tumors, to sensitize the tumor as patient goes for radiotherapy. But in cases whereby the disease has really progressed, and we need palliative approach or palliative care, then we should be able to take care of this patient holistically remember the basic needs of a patient. One of them is nutrition. So insertion of a gastrotomy tube for nutrition. The other times, if the tumor is resectable, the patient is unable to swallow, we might end up with a stenting so as to give this patient a better quality of life. They are able to feed and go about their life normally. So for the outcome of treatment, especially in esophageal cancer, the outcomes remains grim, particularly here in Kenya and the rest of the sub-Saharan Africa. But the reason for this is because the patient presents at an advanced stage. The mortality rate for esophageal cancer is about 97.2. So you can imagine, yeah, for every 10 patients, over 9 patients of them might succumb due to esophageal cancer, especially now when it is diagnosed at a later stage. But one of the things that we are saying and we are sensitizing our population is that this disease can be detected early. And when it is detected early, it is the single most important factor for improved survival beyond 5 years, 10 years, 15 years. Because if detected early, it's treated early, and in fact, we can say with early detection, we might go to total remission, or rather, even achieve cure, unlike when it is in stage 3 or 4. Then we have gastric cancer. This one, I know it's an interesting one in Kenya, and Kimathi can confirm this. Yeah, Anthony can confirm this to us. Almost every other cancer, almost every out of every 5 patients who visit our primary health facilities in Kenya will be diagnosed with gastritis, yeah, or peptic ulcer disease, or yeah, those are the diseases whenever one presents with gastrointestinal problems in Kenyan setup. It's good to note that gastric cancer is majorly driven by the infection, that is Helicobacter pylori infection, and it remains a major gastrointestinal threat across the East Africa. So again, gastric cancer is the third leading cause of cancer-related mortality globally. I think I was looking at some statistics other than Africa. Also, we have Asian countries, but the incidence varies across various sub-Saharan Africa. For example, in Tanzania, the prevalence is around 8.9 when patients are screened for using endoscopy, with a mean diagnosis age of around 59 years. So you can see just pre-retirement age of around 59 years. Yeah, this is the mean age of diagnosis for the gastric cancers. So what are the key risk factors? Already we have mentioned this. And there is a whole pathophysiology as to how H. pylori end up causing changes on the cells until they become malignant. Then again, other risk factors, cigarette smoking. Cigarette has got many carcinogenic agents, so this is another risk factor. So what are the clinical presentations? That is the signs and symptoms. Majorly will present with upper abdominal pain as the most common symptom. So like I was saying, so many patients will come complaining of epigastric pain. They will do probably an investigation, either antigen or antibody test on H. pylori. It's positive. They are given the treatment, the triple therapy treatment for peptic ulcers and gastric ulcers, but within no time, it recurs again. Then we have unexplained weight loss, abdominal fullness and early satiety, and also in later stages of the disease, vomiting and persistent indigestion occurs. So for upper GI, how do we do the diagnosis? Again, the gold standard for all the GI cancers, the gold standard is endoscopically. So upper GI endoscopy with a biopsy, of course, for analysis for histology. Also, we can do H. pylori testing, either urea breath, the serology, or the bios. Now, the more objective one is the biopsy-based H. pylori testing. Yeah, not the one that we do the antibody in our setups. Of course, for staging purposes, we have CT scan. We would like to know which are the lymph nodes that are involved. Yeah, because remember in our classification, TNM, yeah, the tumor size, the nodes. So how many nodes have been involved, and is there any metastasis either to the nearby organs or distant organs? We would like to know that for the purpose of classification. And of course, this again, you can do PET scan on top of the CT scan, just for classification. So treatments, again, if it's early stages and it is operable, then surgery. It can be either partial gastrectomy or can be total, but rarely do we do total. So majorly to be partial, because if it's total, then it's inoperable. I know Paul will be giving an input on that. Then we have chemotherapy treatment. So again, here the chemotherapy can either be adjuvant or neoadjuvant, or at times can be just palliatively, whereby we want just to manage the signs and symptoms. And the radiation therapy, it can also be an option, either as an adjuvant role or neoadjuvant, though most of the time we'll find it as an adjuvant role. Specific outcome data for Kenya is very limited, because we have very few cancer registries in Kenya. In fact, it's now that the government is trying to create a regional cancer registries to give us the accurate data in regard to cancer status in the country. But globally, the prognosis is quite poor for advanced diseases, and H. pylori eradication represents a critical preventive strategy that could reduce incidence significantly. And it starts with simple steps as having safe, clean drinking water, or treating the water that we take. Then we have colorectal cancer, which is another growing concern in our region. Although as compared to other parts of the globe, it's a little bit rare in Africa, but now the colorectal cancer is rising. In fact, in Kenya, we have seen a rise. I don't know, it's because we have increased our screening. I don't know whether we have better accurate and better diagnostic measures, or it's a new and emerging disease. But for sure, in our setup now, there's a rise in the colorectal cancers. Some of the speculations around that is that there's a there's use of we are using similar diet as the Western countries, and also there is so much lifestyle changes as the Western countries. So in Kenya, the data suggests that colorectal cancer in Kenya is emerging through studies at tertiary hospitals documenting its clinical pathology profiles. And the global incidence is rising, and Africa is following this trend. We have agreed on that. In fact, you go like hospitals like Kenyatta National Hospital, Kenyatta University Teaching, Research and Referral Hospital, Moi Teaching and Referral Hospital. The cases of colorectal cancers they see are huge. And for colorectal cancers, you find that those who have been diagnosed with an early disease, most of them will end up with a colostomy. So whereby to rest the gut, we just divert the colon to resect the other part of the colon that had the disease. They get their treatment and then go for reversal. So the stoma therapies, of which I am also one in Kenya, I can tell you right now, most of the stoma or the osteomates we are seeing in the country are as a result of colorectal cancer. So these numbers are rising. Initially, the patients we were seeing were majorly due to trauma, gunshots, and such cases. But right now, majorly, it's the patient diagnosed with colorectal cancer. So what are the risk factors for colorectal cancer? This list is not exhaustive, but it's the key ones. One, the low fiber and low fiber diet, and then also high red or processed meat diet. And you can agree, this is right. The nyama chomas in Kenya, Dr. Paul, you should come across and eat some nyama choma, though they are not quite healthy. Obesity and physical inactivity. So we have more people living in sedentary lifestyle. Familial history and genetic predisposition. So whereby has been an history of a colorectal cancer or any other cancer, because sometimes these genetic mutations at times might be present for several diseases. So one of the family members might had breast cancer, but you find the other one develops colorectal cancer. And if you follow, you find a correlation in terms of genetic mutations or something of the sort. So inflammatory bowel disease is another one of the key risk factors. So those are just some of the common risk factors. On the symptoms, how does the disease present? This one, it's good to note what is your bowel pattern. Yeah. And then in case of a change of bowel pattern, it's good to understand your body, what could be going on. So any change of the bowel pattern could be diarrhea or constipation. So it's good to take note of that. Bloody stool, persistent abdominal cramps, the gas, the pain and all that, unexplained weight loss and fatigue. But most of the time we'll find that unexplained weight loss will come with an advanced disease. At an early stage, probably we'll observe one or two, like either change in bowel movements or the bowel habits and the bloody stool. For diagnostic workups, again, we said the gold standard for these ones is endoscopical. This one now will be colonoscopy. Colonoscopy, the biopsy. This one is the gold standard diagnosis for cancer, colorectal cancer. We can do CT colonography, CT abdomen and pelvis. In fact, even before we go for the staging, one of the ways that happens in our trauma setups is that most of the time the patient will present a little bit late when there is total obstruction. Yeah. So because of the intestinal obstruction, and there are so many causes of intestinal obstruction, when a CT scan is done, a mass will be noted. So that's one of the ways that diagnosis can be done. But again, now you can use CT scan for the purpose of staging. Of course, use of PET scan again for grading of the for the staging of the disease, and at times it may come even to check the status of the disease after treatment and CEA tumor markers. It's something that it's done just to monitor, and especially whereby probably you're not quite sure, like the CEA can be done. If they are borderline, then can be repeated. And this is whereby you are correlating that to the results of the colonoscopy. Yeah, so the colonoscopy results were not really definitive, but for example, the CEA tumor markers on the borderline. So these are patients who might require a close follow-up in future, just to check whether there are any changes on those tumor markers, because that can, even if colonoscopy didn't show presence of a disease, it can suggest still a repeat of the same of the colonoscopy to identify whether there is disease. Treatment, I think this one, like we have looked in the rest of the cancers, there are 3 treatments we can either do. We do surgery, chemotherapy. Rarely do we do radiation therapy for the colorectal cancers because of the high motility of the colon. At times, radiation might not be the most preferred, but the instances where yes, that has been indicated. But majorly you will find the primary treatment is surgery. But because after the resection, the surgeon might not be very sure about a resection of the entire tumor, then chemotherapy is done. And there are different regimens of chemotherapy that can be administered. So like I was saying, colorectal cancer progression is highly stage dependent. So the earlier the stage, the better for getting to total cure. An early stage disease, that is stage 1 and 2, carries a good prognosis with surgery alone. But in Kenya, I would like to hear what is happening in the other side of the world, in the US. But in Kenya, it's almost a standard practice that I don't know whether we don't believe in our knives, or, but in Kenya, rarely do we do only the surgery. You will find a surgery is done followed by chemotherapy. Then in stage 3 and 4, disease requires multimodal therapies with significant reduced survival outcomes. And here you just do palliative symptom management at this level. In fact, even the diseases might be adjusted not as high as it were if you are treating stage 2. Yeah. But the most important thing, as we have said, is we should screen for these diseases, and it will dramatically improve, yeah, diagnosis at early stages in our setup. Finally, we have pancreatic cancer. This one is silent but deadly. Yeah, if we can describe it so. I think I started by describing this, how almost all clinicians at basic level will always miss. Yeah. In fact, this index suspicion of pancreatic cancer in Kenya is minimal. Yeah. The symptoms will mimic other diseases like diabetes. We treat diabetes, and for our like a year or 2 years, the patient is okay only to present now with a palpable mass. That's when we start thinking, oh, this could be a tumor. So this one is notorious for late presentation and poor outcomes. And pancreatic cancer demands urgent attention in Kenyan setup. But unfortunately, this is one of the cancers for the last 8 years that I've practiced in oncology setups. I have seen, I have no a positive outcome of a patient whom I have seen with a pancreatic cancer in our setup for sure. So like I was saying, there is a grim prognosis of pancreatic cancers in Kenya. And again, there's a disproportionality in terms of how it's distributed, with it affecting relatively a younger population, and young here with a median of around 58 years. And studies indicate that there could be an increase of these in future. So what are some of the risk factors for pancreatic cancer? Smoking, alcohol use, we know that. Diabetes, especially when it is long-standing diabetes, one with diabetes for over 30-40 years. So the long-standing diabetes, chronic pancreatitis, obesity, and of course the family history. Yeah, genetical predisposition is the key to development of any cancer. So like you can see, over 54% of them are metastatic by the time they are diagnosed, and most of them present with a distant spread. Distant spread means that already they have metastasis to the liver. No, not probably there is a metastasis to the either to the liver, to the chest, and all that. But rarely, some of the cases that present early, a surgical resection can be done, which is around 7% of the cases. But in our setup, I can say this, that it's a very small fraction of patients who qualify for curative surgery. So unless if it's just a palliative surgery, of which it's rarely indicated, then only 7% who really qualify for the curative surgeries. So that brings us to the end of our presentation for the 4 cancers. I think you appreciate the magnitude of these cancers in our setup, and also the clinical overview. I know it might not have been too detailed, but yes, it gives a picture of the epidemiology. How do we basically diagnose, and the basic management. We might not have gone to, because as I said, this presentation has got both the clinical and non-clinical. We have not gone to the details of saying we use 5-FU, cisplatin here, or which regimen particularly use, but we have covered the basic principles of principles in GI cancers management. So thank you, and back to you, Anthony and Paul Hart. And Paul Hart, I'm looking forward to hearing what's the situation in America, which are the most prevalent cancers over there. How do you manage some of these cancers? Yeah, like I've told you, I have mentioned, for us, rarely will you just do surgery and sit. We just do surgery and continue with chemotherapy right away, because I don't know whether it's because we don't trust ourselves, or you share the knowledge from the other end, how it is done. Thank you, and back to you, Anthony.
Thank you so much, Kinoti. I'm proud of the presentation and the detailed presentation that you have offered. the fact that you went ahead and included the statistics in Kenya. In the interest of time, before I give Dr. Paul room to give his input, I know there are 4 or 5 questions in the platform. Let me go through them as either you, Paul, and Kinoti responds to. So we have the first question from Mbogori. He's asking, he's saying, a very good presentation and experienced presenter. Kudos to you, Justin. My biggest concern is stomach cancer. Due to recurrent H. pylori infection, many people are suffering and returning to traditional regimens for management of H. pylori. The other concern is pancreatic cancer. What are the warning signs? What symptoms should we provoke a patient to go for pancreatic cancer screening? To you, Kinoti.
Yes, thank you. Thank you, Bogori, for the question. The one that I have captured is on pancreatic cancer. What are the symptoms? Like I said, pancreatic cancer is one of those cancers that are silent in nature. Rarely do we have a standout symptom, and Dr. Paul will be confirming this. Most of the time, it presents mimicking with a mimic to diabetes. So it needs a high suspension index, like I said, and probably doing the tumor markers at an earliest opportunity possible, and especially whereby has been a family history, rather than waiting for a patient to present with symptoms, because the symptoms, when they come, it means it's a late stage disease. So all I can say is that we might not have this classical symptom that we are looking out for, but rather based on the history, especially the family history, a presentation of some um, of the diabetic like symptoms, then it's good to also screen for the tumor markers related on the same. Don't know whether Paul has got an addition on that.
No, you're absolutely right about pancreatic cancer is silent. In all my years of practice, I only had one patient who was cured of pancreatic cancer because they found it very early and they were doing a GI surgery for another reason. And when they were looked around the abdomen initially, they spotted a suspicious area was cancer. They did the surgery, but really hard, asymptomatic. Um, and if the patient is really lucky and the doc thinks of it, you may have a chance. It is so difficult to diagnose early. Unlike, if you're thinking of stomach cancer, where people are going to present with discomfort or new onset, and if there's a little bit of bleeding and anemia, that which you work up, is the same with the lower tract for the GI cancer. But pancreas is so difficult. And that's not unique to Kenya. That's worldwide, as far as I understand. Now, I'm not a cancer specialist. I'm only a family doctor, you know. But yeah, very difficult diagnosis to make with terrible outcome, unfortunately.
Thank you. Thank you, Dr. Ari. So I think the second part of the question was about the recurrence of H. pylori that is causing stomach cancer. That is true. On that, we should be talking about total eradication. The H. pylori is a bacteria. Bacteria can be eradicated. And we said one of the ways is having safe, clean water, especially in areas whereby there is use of bowl and wells. Yeah, we should not just take water directly or any underground water. That is one. The other side part of the question is that I think the use of alternative and complementary medicine, that is the traditional regimens for management of H. pylori. I will not comment on that. Basically, I would say we just should do the standard triple therapy management of H. pylori. Because there are no studies that have shown any benefit in terms of use of these traditional regimens of treatment. Thank you.
And it's
Thank
interesting if you
you.
look at H. pylori worldwide, there is actually a major variation. In Africa, it's the highest with 58 to 70% of people having H. pylori. Asia 46 to 55, US 47%. But worldwide, it is a major, major infection. So, the problem is when you have such a prevalent infection, yes, there's going to be a, statistical risk or association with cancer. And also, a lot of folks who present with symptoms that could be H. pylori, at least in the States, are not treated. They come into a regular provider's office or over the counter. And I don't know about over the counter medicines in Kenya. You can get omeprazole, you can get famotidine, and people self-treat. So if they have, they're curing their symptoms, but they're not treating the disease. And even when they go to some docs, they're just given symptomatic treatment and they don't get a diagnostic study.
Thank you. Thank you for that, Dr. Paul. I think in the interest of time, I will try, we go through the questions as fast as possible. We have a question from Martin. Thank you for this informative presentation. I'm much concerned with esophageal carcinomas. When it comes to surgery, which prognosis mostly are poor? Can a multidisciplinary approach bring any better outcome since stenting is just for a period of time and the disease progresses to complications?
I think generally, yes. I mean, if you have a multidisciplinary approach for any form of illness, including cancer, I think the patient is going to get a better outcome. And it also is for esophageal cancer, it depends how early you pick it up. I mean, years ago, I had a patient in my office was talking about something else and happened to say, by the way, when I'm swallowing, food seems to catch. First thought I had is, could there be a malignancy? Did the study 2 days later, and he had a surgery a week later. It was early. We were lucky. Doesn't always happen that way. People can often say, oh, I ate the wrong food. I ate too quickly. It's the way the food was prepared, and it progresses. So one, it's our responsibility as providers to think of cancer. And two, we hope that our patients present early enough.
Thank you. To Dr. Paul and Kinoti, at what age do you advise men to have annual checkups, inclusive of colonoscopy?
Between 40 and 50. It also depends on family history. I mean, if you have a strong family history, you want to start earlier. But if there's no family history, asymptomatic, the US is between 40 or 50 for your initial colonoscopy. And then it depends what they find. If they find a polyp, even if it's not malignant, you have it much more frequently. If it's benign, every 5 to 10 years. And you stop at age 70 to 80.
Yes,
What
I
about our
totally
setup,
agree with
Kinoti?
Yes, I totally agree with Dr. Paul. It's between 40 and 50, but our standard practice in our setup, we start at around 50 years. But if there is a positive family history, uh, what is advised as per our guidelines and also World Health Organization is that you start 10 years earlier. Like if in the family someone has been diagnosed with, let's say, colorectal cancer at the age of 50, then the family is advised to start screening at 40 years. And again, now, as Dr. Paul has put it, is if what is found like the polyp or something suggestive, then the screening might be done more frequently, at times even yearly or every 5 years, depending now on the findings. But the first colonoscopy is advised between 40 and 50, whereby there is a positive family history, then 10 years earlier from the time the family member was diagnosed.
Thank you.
Back
Thank
to
you. The next question comes from Han. Han is asking, good evening. On the gastric cancer, the suggestion of elimination of H. pylori was given. How are we as a country in Kenya trying to address this? And the second question, how can we handle the menace of the bacteria from our homes, given the diet and the lifestyle mentioned as a predisposing factor? To you. So the first question is, what are we trying to address the prevalence of H. pylori as a bacteria in our setting, and how can we handle the bacteria from our homes, our lifestyle, our diets? So sometimes we feed from outside hotels. How do we address this issue? Kinoti?
Yeah, thank you. I remember when we were growing up, we were very, as a country, we were doing quite well in prevention of the communicable diseases. But along the way, when devolution came, it seems like we dropped the ball. Remember, right now, public health officers are not a frequent field officers or visiting the fields as often as they were back then. So I think one of the things we have done is that we have dropped the ball of the basics, because for eradication of H. pylori is just doing the basics, the hard wash, the boiling the drinking water, treating the drinking water, ensuring that the food handlers are licensed and they are using clean water and all that. So I think if we just revisit the basics of public health, then as we treat other diseases, including the diarrheal diseases and all that, we shall also be addressing this particular issue on H. pylori. Thank you.
Yeah, and I think to add on that, our setting most of the time we find, and this is so common, let's say the triple therapy medication, you find medication is costing between 3,000 to 5,000 Kenyan shillings. And then you find someone has 1,000 shillings or 1,500. When they go to the chemist, they give them the half of the dose. And then when they get better, they don't go to get the other half. So we are as the clinicians or the pharmacists or the healthcare providers in the settings that we are contributing factor, in the sense that we are creating an antibiotic resistance to the H. pylori. As most of you know, H. pylori is a bacteria, Helicobacter pylori is a bacteria, and when you start the treatment, the triple therapy, where you have the PPI, the omeprazole, and let's say the clarithromycin and the amoxicillin. And as you find, we give it at a high dose of, let's say, 1 gram. Sometimes we find that we have given half the dose and we have left it at that, and we don't follow up on the patient again. When the patient comes back again, the Helicobacter pylori has started creating a defense mechanism against those medications. And that's why you find sometimes some of these kits have even to a point of having levofloxacin and clarithromycin, and they even go not triple but quadruple the dosage of the medication. Please, as the healthcare givers, let's try and work on having these patients complete the whole dose of medication. Sometimes it may even go for a month, but make sure that they have followed the right procedure in medication. I think that's answered. What are the causes of an inflammatory bowel disease, and what are its signs and symptoms? This will go to Paul.
I'm sorry, I missed that. What are the what, please?
What are the causes of IBD, that is inflammatory bowel disease, and what are its signs and symptoms?
Okay, causes, numerous causes, but there are some familial causes that people have. Crohn's disease runs in families, ulcerative colitis you can have. I'm not sure of all the causes, but I will send you an answer with that answer. Uh, Abdominal pain, change in bowel pattern, are probably the two common things you have for irritable or inflammatory bowel disease. But I will send that as a much more detailed answer.
Yeah, so I think in the interest of time, I will answer two more. We will answer two more questions, and then I have all your emails after this presentation. You will get the presentation, you will get the recording, and you will get the answers from Dr. Paul. Dr. Paul and Kinoti will sit down and come back with answers on these questions. So the next question I will give it to
Anthony, I
yeah,
don't know
Kinoti.
what's happening to your internet.
Is it mine or yours? I think it's yours. Paul, can you hear me well?
Yeah, I can hear you perfectly. Just to answer
Yeah,
one of the next questions really quickly, is the role of exercise really helpful? Interesting enough, if you look at the different cancers with a reduction of risk, colon cancer, 8 to 14% reduction, endometrial, 10 to 18. Interestingly enough, esophageal carcinoma, up to 42% lower risk with exercise. I'll give for all the questions that we have here, I'll go and give information with a link to the sources so people can look at, if they want, where that information comes from.
thank you. And then the next one is how best may we treat gastric ulcers and prevent it from causing gastrointestinal cancers? That is George Atiang from Uganda. He's asking how do we make sure that we have eradicated these gastric ulcers and these gastroesophageal reflux conditions to avoid it progressing to gastrointestinal cancers.
Might I suggest that we answer these in writing?
Yeah.
If that's
So
okay. I'm
I
sorry,
will
I'm not
do
trying to
this.
cut anybody off.
I understand, and I think I see some very good questions from Kunja William, Albert, Salome, Kaburo, Atiang, Joyce, Han. I think Ronnie, I think what we'll do, and William, please forgive me in the interest of time. I know the presentation was great, and I will keep Justin and Paul and make sure that they respond to all these questions. I will send you the slides because I have all your emails. Everyone that has managed to join today will get the presentation. That will be what I will be doing tomorrow because I know tonight Dr. Paul will go through all the questions and respond to them. When he responds to them, he'll send me a detailed presentation on the responses, and then I will attach them as part of the presentation and forward to every email that managed to reach out to us. I will, when you see my email, please respond to it if you want. Anything that you need from us, please respond. Kinoti being here and Paul. Yeah, Dr. Paul?
If I could add one more thing, please, for all the respondents, all the people who have come, please send us suggestions for what you want us to present about, because we want this to be meaningful for you. What topics would be most helpful? We try to come up with topics which we think are valuable, but I'm in I'm in the United States. I'm not in Kenya. I don't know the problems you are facing every day and the issues which you'd like to have this type of discussion. And as an aside, thank you for the presenter. This was, I think, one of the best presentations we've had. He did an amazing, phenomenal job. And I hope to do it again with him.
Thank you, Paul. Kinoti, I will reach out to you I think Ambrose is saying, let's talk about dental health next time. Please, when you see my email, please input it there so that I can go through every question, every suggestion, and we will create a topic around it. I think since Kinoti is a specialist even in wound care, it might be one of our topics in the future months as we prepare a presentation on wound care. I think most of you have come across wounds and how to take care of them. And there are very many new ways of new presentations on how to work on wounds and not any type of wounds. So any management that we come across, we'll share with you. If we plan to have it as our next presentation, we'll do. But please, if you see my email on your inbox, or if it goes to your spam box, please be on the lookout within the week, and then forward me the presentation that you would like us to talk to about. You'll get the slides and you'll get the answers and you'll get the recording. Thank you, everyone. I think Holly is not with us. Yeah, she has joined another meeting. Kinoti, I say thank you so much for availing yourself in a very short time and a very great presentation. I think everyone here is impressed and very happy. If we reach out to you again, I hope you'll be available. And for giving your time to these frontline healthcare workers, and always to the panelists and the attendees, I thank you so much for always availing yourself when we call you. Every month we have a webinar, and next month when we call you for a webinar, please avail yourself. Share this among everyone, every healthcare worker that you work with, everyone that you come across, share with them, and we will grow together. Thank you so much. The meeting has been adjourned officially. Bye-bye,
Thank you
everyone.
so much. Bye-bye.
And have a good evening.